Hello and welcome to my video for APS402 on abdominal assessment. For the purpose of this video, I don't have any assessment tools with me, and Craig will be playing the role of my 25-year-old female patient who's presenting with generalised abdominal pain. We're already on the stretcher in the back of the ambulance, but I will start my assessment from top to bottom so you can see how we go. Hi Craig, my name is Alistair, I'm from the ambulance. How are you today?
Oh, pain.
Okay. Straight away I can see my patient looks well, so airway, breathing and circulation is all normal. I can go straight on to my history taking assessment. There are multiple different avenues you can use. I'll use sample for my history and dollar for my pain assessment. Craig, are you able to please describe to me what is going on? Why are we here today?
Oh, I've had this pain for like 3 days, sort of in my guts.
Okay.
And I was driving today and, oh God, driving in the car, everything in the car was making it so much worse. Oh.
Okay. So the bumps on the road that you haven't had for the 3 days made it worse today, did
they?
Yeah. Okay.
Yeah, just, oh.
Okay. With that pain, have you also felt any nauseous, vomiting, diarrhea, or anything along those lines?
Yeah, I've been feeling really sick,
Okay.
And then I've vomited.
Okay, all right, that's fine. At this point in time, my partner has already come back with a set of vital signs, which we'll get to later on. Craig, are you allergic to anything at all?
No.
No, not at all. Do you have any past medical conditions at all that I should be aware of?
I've got asthma.
Asthma, okay. Do you take any medications for that?
My Ventolin.
Your Ventolin, okay. When was the last time you ate or drank, Craig?
Well, it was 7 o'clock this morning, but I've not been eating much food at all.
Okay.
Sort of just not feeling, I've been able to drink, but just not feeling like food.
Okay, no issues at all. And you mentioned you've been able to drink and you've had poor food intake. So have you just lost your appetite, have you, for the last couple of days? Okay. Yeah. And with your drinking, have you had any issues when you go to the bathroom at all?
No.
No, okay, that's fine. All right, so from here, we've mentioned pain. I'll now go on to my dollars assessment for pain. Craig, can you just describe what that pain is doing and where it is, please?
Oh, it's just this pain sort of here. It's
okay.
Just, yeah.
So Craig is indicating actually a more lower right quadrant abdominal pain. Okay, can you describe what it feels like?
Oh, it's really sharp. Someone's stabbing me.
Okay, so a sharp and stabbing pain. And you said you noticed that 3 days ago.
Yeah.
Okay, so onset of 3 days ago with an increase in pain over the last couple of hours. Initially it was central, was it? So more epigastric?
It was just discomfort and everything sort of here, but yeah.
And now it's moved to lower right?
Yeah, now it's over here.
So over the 3 days we've had a progression of disease down to our lower right quadrant. Has anything you've done made that pain any better or worse?
No.
No? Okay, that's fine. And you mentioned you've got some other symptoms, including nausea, vomiting, and you feel a bit hot and cold.
Yeah.
Okay, that's fine. If you had to score that scale, 10 being the worst pain you've experienced and 0 being none, initially, what was it? And then what is it now when you hit those bumps in the road?
Oh, look, 6.
Yep.
But, no, driving, 10. Oh,
okay,
God.
So it's the worst pain you've ever experienced?
Yeah.
Okay, that's fine at all. From here, we've got our history, we've got our pain assessment. I'll now get the vital signs that we've already achieved. So perfusion status, conscious state, and my respiratory status. Craig, just for the purpose of this examination, is a fit 25-year-old female that weighs about 65 kilos. So not obese, pretty regular in all those avenues there. Her heart rate is sitting at 100 in a sinus tach on the 12 lead. Her blood pressure is sitting at 110 on 70 with a rest rate of 24 and a clear chest to all bases and fields. Her SpO2 is at 97 on room air with a temp of 38.0, BSL of 5.0 and a GCS of 15. So with those numbers there, we notice that she's slightly tachycardic, potentially due from a pain response or an infective pathway, which would also suggest the temperature of 38. Okay, Craig. What I would like to do now is I would like to go into a more detailed secondary assessment of your body, if that's okay. From here, just a simple head to toe with obviously a more in-depth review of his abdominal region. Looking at his head, I'm looking for things like jaundice. So when we open the eyes down, I note that it's nice, white, clear, no yellows at all. Suggestive of potentially liver disease and liver cirrhosis. I note none of that. Looking at Craig's neck when he sits there and turns to the left, I note normal jugular vein pressures, nothing there at all as well, and no spider veins, also again suggestive of liver disease. Coming down into Craig's chest, I notice equal expansion, nice clear chest, nothing of any note there. Down into Craig's arms, and in particular his hands. Craig, what I'm going to get you to do is just to sit up for me. Perfect, so there. And pop your arms straight out for me. And flip them back. Okay. Noticing no tremors at all with his eyes closed, suggestive again of a hepatic cause. Can you then present your fingernails to me? Perfect. So noting no clubbing of his fingers at all, again, suggestive of hepatic and renal disease. If you then flip your hands over for me, Craig. Beautiful. I notice nice, clear, no redness at all, again, hepatic nature. Pop your arms down by your side for me, and we'll just sit you back. Is that comfortable?
Yep.
Okay. From here, I would like to auscultate his abdomen before I palpate it. With my diaphragm of my stethoscope, I'm going to auscultate his abdomen, listening for bowel sounds. Now, I'm going to listen for 5 to 10 seconds to hear the bowel sounds, with up to 2 minutes required before I can rule in an obstruction. Okay. Starting in the left lower quadrant, listening for 5 to 10 seconds, hearing nice bowel sounds, and moving along the colon that I would expect to hear, noting nice bowel sounds. Beautiful. Okay, from here, I'm going to listen just above the liver to hear any regurgitation of any arterial, which is normal, and above his umbilicus again. Again, distal. From here, general palpation. I note Craig's pain initially was central and is now lower right quadrant. I'm going to start very superficial with general light pressure using the whole palm of my hand, and then becoming a bit deeper as I go. You would normally start away from the pain that Craig presents with, so I will start on the lower right quadrant. Just tell me if there's any pain at all when I press. No pain there. At this point in time, I'm also watching Craig's face for any guarding or grimacing that I might feel and might exacerbate. There's no pain there, no pain there, no pain there, and mild pain there. So from Craig's face, I can see that he's got some mild grimacing at that point. Again, I now go a bit deeper. With my already diagnosed differentials in my head, I'm working and looking at potentially a liver cause, potentially appendicitis in the location of the pain. Craig being a female, potentially a pregnancy-related issue, and potentially some sort of kidney disease. We'll get to all that a little bit later on, just with that in the back of my mind. Pressing a little bit lower and harder now on his left lower quadrant. Do you get any pain anywhere when I let go there?
Yeah.
What does that go to?
Over here.
Okay, so Craig's indicating some rebound tenderness, which is also called Roth's sign. That's indicative but not diagnostic of appendicitis. So with that in mind, I'll continue on. Any pain here? No. Any pain here?
No.
And any pain there?
Yeah.
Okay, so general discomfort on the lower right, increase in rebound tenderness on the lower left. Okay, I would expose Craig's top and expose his chest, looking for different signs. From here, we can have things like Cullen's sign. When you have pancreatitis, you can have some bleed and irritation there. Cullen's sign presents with bluish or red nature just above the umbilicus. Okay, while I was up here, there's none there. I look on the sides again for any further bleeding, Gray Turner's sign that's known as, again for pancreatitis. I note none of that for Craig. His history of no diabetes at all, besides no medications or past history besides asthma, suggestive that it might not be pancreatitis. Those signs there, again, not diagnostic, but less likely. From here, in the upper right quadrant, I'm going to investigate for potentially gallstones and inflamed gallbladder. Craig, what I'm going to do is test for Murphy's sign now, okay? With your upper right quadrant, I'm going to find your lowest rib, and I just want you to take a big breath in for me. And out. And one more time, pressing a little bit deeper this time. And out. Is there any pain there at all? No. So the negative Murphy's sign is, again, suggestive, not diagnostic, of cholecystitis. So the lack of pain there when we press on the potentially inflamed gallbladder, states that this is less likely to be cholecystitis. There is no signs of any jaundice or any potentially hepatic cause that we've found so far. Again, less likely to be a liver disease. At the moment, all we have found is left lower quadrant pain on rebound to his right, generalised right, initially starting in the central, now radiating down. Craig, my next assessment, what I'm going to get you to do is to please lie on your left side. Okay. While Craig's in his left lateral position, I'm going to get you just to passively flex your hip for me if you can. Does that hurt anywhere at all?
Yeah.
Where does that hurt?
Here.
Okay. Just relax back onto your back for me. So that test there is the psoas, which is a test that when we put pressure on the ligaments and the muscles there, we react with the potentially inflamed area. Again, not diagnostic, but very suggestive of our appendicitis. Working down, I'm looking at the pelvis, and straight away I think with a female of 25 years old, Craig, is there any chance you're pregnant?
No.
Are you sexually active?
Yes.
Okay. So straight away, although Craig believes he's not pregnant, he is sexually active at childbearing age. We'll have to further investigate that in hospital. Craig, might be a personal question. Your menstrual periods, are they normal for you?
Yes.
The last one being within 4 weeks rather?
Yeah.
Yep.
A couple of weeks ago.
Beautiful. Okay. Less likely that we're pregnant, but not diagnostic again. Looking down into his legs, I'm looking for any pitting edema, good cap refill, which we don't. We have good cap refill, but no pitting edema. Craig, can I just get you to sit up for me? And I'm going to look at your back. From here, I'm going to palpate his kidneys. Are there any pain here at all?
No.
No. Okay, I'm going to then tap on your kidneys and you just let me know if there's any pain.
No.
No?
No.
And no. While I'm here, I'm going to check for sacral edema by just pressing my hand and then letting go, which I have none. You can sit back for now. Okay. At the moment, suggestive but not diagnostic of appendicitis is where we're looking at. We've potentially ruled out hepatic causes, gallbladder, kidneys and urinary infections. I just forgot to mention on your pelvis, Craig, you said earlier that you've had normal and good fluid intake. Has there been any issues when we're passing urine at all? Any off colours, smells, bloods?
No.
Nothing at all. No pain at all and nothing there. So not diagnostic, but very suggestive that maybe UTI is also in our nature. From here, I don't have it with me, but currently in my ambulance service, we have the ability to take bloods and use the iStat machine as well as an ultrasound. I would use this here. With the iStat machine, within a couple of minutes, I'm able to investigate a full blood count. And what I would be looking for, and what has actually been found by this iStat, is an elevated white cell count, suggesting an infective pathway, and an elevated C-reactive protein. Those two together, highly suggestive of acute appendicitis, of acute appendix rather. With the ultrasound, I can, because I'm a very skilled and trained professional, I can look for any free fluid within the abdomen, suggestive of any trauma or any bleeding. Have you had any trauma recently?
No.
No trauma. So if I found any free fluid there, I would be querying maybe an ectopic pregnancy. With my very skilled set, I can look for the uterus and see if there was an impregnated patient there, which there is not. Not diagnostic in the pre-hospital setting, but highly suggestive that ectopic pregnancy is very unlikely. What I am looking for, however, with the lower right quadrant where my pain is the appendix. So this is identifiable by the lack of peristalsis compared to the rest of the colon. And as a result, looking at the appendix, I note it to be greater than 6 centimetres in diameter. Now that there is very suggestive of an inflamed appendix, and in this patient, an acute appendix. At this point, I would further investigate the pain that Craig said. He's noticed that he's actually had an increase in pain over the last couple of days. Had Craig said he had an increase in pain and then a sharp reduction in pain without any further investigation, I would be very suspicious of a perforated appendix. However, as Craig's pain is still presenting up, we need further investigation up at hospital. The things that I've found today are suggestive of an acute appendicitis in regards to the pain, the rebound tenderness, the temperature, elevated heart rate. while ruling out a few other differentials, suspected ruling out. Once we got up to hospital, I would be explaining to Craig that the hospital is the best course of action for today. If we left you at home with some antibiotics and some general over-the-counter and pain relief rather, he has a very increased chance of this developing further. And also without the scans and the invasive manoeuvres that they can do in hospital, we have the inability to rule out anything further and more sinister. Craig would present up at hospital with the ambulance, and once up there, he would do a urine test to rule out ectopic pregnancy first and foremost. With that, he would also have further blood tests to monitor his inflammatory mediators and pathways. We would manage his pain accordingly as per every ambulance CPG. We would manage his nausea and vomiting, again, with respect to your local ambulance guidelines. And the only way that we can truly rule in or out, if Craig was a pregnant patient, would be with an MRI. However, with Craig not being a pregnant patient, the CT is still the gold standard for any abdominal invasive manoeuvres. So I hope this has been very enlightening. I hope that you've learnt something. I hope that I've covered all the things for you. And thank you to Craig for your time. Thank you very much.